Welcome to the treatment of concussion in the orthopedic population, presented by Megan Castellano, Cynthia Dvorsky, and Megan Murphy. The course outline will include a review of the anatomy, evaluation and assessments, sideline examination, outpatient examination, documentation, treatment, and we're going to go over a few case studies. Following this course, participants will be able to apply current evidence to the evaluation and treatment of patients post-concussion, demonstrate proper evaluation for oculomotor, balance, vestibular, and strength for treatment in concussions, create plans of care for patients following concussion with current evidence and best practices, discuss and manage psychosocial influences in treatment of patients and athletes post-concussion, explain how to determine appropriateness of oculomotor therapy versus vestibular therapy versus strengthening based upon symptoms post-concussion. Discuss prognosis of concussions as well as positive and negative prognostic indicators. Provide education for patients and clinicians based on red flags, concussion healing time, and return to activity guidelines. There are no conflicts of interest to declare.
We are going to begin our pre-course presentation with some relevant anatomy review. Firstly, let's define concussion. A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes the head and the brain to move rapidly back and forth. This sudden movement can cause the brain to bounce around or twist in the skull, creating chemical changes in the brain and sometimes stretching and damaging brain cells. Or, a quick and easy explanation, concussion is a neurometabolic cascade resulting in an acute energy crisis. So what does a concussion look like? There can be a myriad of different causes for concussion, ranging anywhere from a motor vehicle accident to a sports collision to hitting your head while closing the trunk of your car. A couple of the big take-homes that I like to remind patients is that there does not need to be a loss of consciousness to qualify as a concussion, and there is no abnormality on imaging as this is a metabolic event. Now for the fun part. Our brain is composed of two different tissue types, white matter and gray matter. The gray matter is composed of cell bodies. This is where we conduct, process, and send information out to the rest of the body. This part of the brain is typically fully developed by our 20s. The other 60% of our brain tissue is white matter. This is the axons that transmit the signals from one cell body to the next and help us interpret sensory messages from all over the body. This tissue development peaks around middle age. You might be asking, why does this all matter? Well, the white and the gray matter are different densities. When we have a trauma to the head, these two portions of the brain move and stretch at different rates due to their different densities. This will be important as we explore the phases of concussion. The first phase we're going to talk about is the excitatory phase. This is at the time of injury. In normal brain function, at the most basic level, there are a bunch of molecules inside the brain cell and a bunch of different molecules outside the brain cell. When a signal comes to a brain cell from another, channels open and the stuff from inside goes out and the stuff from outside goes in. This exchange happens and the brain cell gets excited and passes the message on to the next attached cell. When an injury occurs to the brain and it gets stretched, it deforms and pulls in various directions. When this stretch occurs, the channels are forcefully pulled open and we get molecule exchanges and the cell thinks that it's getting signal to fire. So basically, a concussion is millions of brain cells getting tricked into thinking that they just got a signal. This creates an electrical storm in the brain, and this electrical storm burns a lot of ATP, or energy. Now for phase 2, spreading depression. Over the next few days, your energy stores continue to decrease and you hit your peak low. This is usually around day 5 to 7. And then you slowly begin to rebuild your ATP. When your ATP returns to your baseline level, you are considered healed from your concussion. This full metabolic recovery typically occurs between 22 to 45 days post-injury. In a typical concussion, our ATP reduction is approximately 20%, but in more serious TBIs, it can reduce by as much as 50%. At this level of ATP loss, we are at greater risk of permanent damage to the brain tissue. On this slide, we have outlined some concussion facts. Most individuals who sustain a concussion will recover within the first 7 to 10 days following the injury. Children can take longer to recover from concussions as they are still neurologically developing, and it can take up to 1 month to recover. It is reported that 14% of school-age children and 33% of adults have reduced function and symptoms for 3 months following a concussion. Occipital neuralgia is when our occipital nerve becomes inflamed by tissue tightness and is the root cause of concussion headaches. Symptoms of occipital neuralgia include continuous aching, burning, and throbbing, with intermittent shocking or shooting pain that generally starts at the base of the head and goes to the scalp on one or both sides of the head. Patients often have pain behind the eye of the affected side of the head. Additionally, a movement as light as a brushing hair may trigger pain. The pain is often described as migraine-like, and some patients also experience symptoms common to migraines or cluster headaches. The greater occipital nerve is the biggest purely afferent nerve that arises from the median distribution of the dorsal ramus of the C2 spinal nerve. It runs backwards between the C1 and C2 vertebrae and transverses between the inferior capitis oblique and the semispinalis capitis muscle from underneath the suboccipital triangle. While traveling to the subcutaneous layer, the greater occipital nerve is found to pierce the semispinalis capitis muscle in most cases, and in some cases, the trapezius and inferior oblique. This complex involvement with the nearby musculature may make the greater occipital nerve a potential source of nerve compression, entrapment, or irritation. The greater occipital nerve then perforates the aponeurotic fibrous layer of the trapezius and the sternocleidomastoid to travel to the scalp and the superior nuchal line. The greater occipital nerve also traverses along the occipital artery after passing through the semispinalis capitis. The greater occipital nerve innervates the skin at the back of the scalp up to the vertex of the skull, the ear, and the skin just above the parotid gland. For treatment of greater occipital nerve entrapment neuropathy, the regions where the greater occipital nerve traverses between the atlas and the axis, the greater occipital nerve courses between the obliquus capitis inferior and the semispinalis capitis, or the greater occipital nerve perforates the semispinalis capitis and trapezius, which are potential areas of greater occipital nerve irritation and entrapment. These zones could be affected by other medical issues such as whiplash injuries and posture imbalances and can serve as possible origins of occipital neuralgia. So what do we do for treatment? Suboccipital release, occipital nerve blocks, pulsed radiofrequency, occipital nerve stimulation, ultrasound-guided chironeurolysis, and dorsal rhizotomy, peripheral neurectomy, and surgical decompression. It is important to familiarize ourselves with the muscles that compose the suboccipital triangle so that we can be more specific with our manual techniques while treating this patient population. Please take some time to review these muscles and practice your palpation to ensure you feel confident with their locations.
Evaluation and assessment. There are 7 domains of concussions, sometimes called categories of concussions. The first is cognitive, which is most commonly seen. People complain about feeling slow, being in a fog, difficulty remembering, and they have difficulty with prolonged or complex mental tasks. Ocular motor, which affects about half of patients with concussions. People report symptoms of blurred or double vision, eye fatigue, accommodation dysfunction, difficulty with saccades or pursuits. Sometimes they say that the words are moving on the page and they have convergence insufficiency. Vestibular, which 60% of people with concussions will experience, symptoms of dizziness, nausea, imbalance, motion sickness. The next is mood or psychiatric. 25% of patients will complain of an overall feeling of anxiety. They also have irritability, nervousness, and changes in sleep in which they're not able to fall asleep or stay asleep. Post-traumatic headache or migraine, which is most commonly reported symptom is a headache. 92% of patients will complain of a headache. Autonomic Symptoms include decreased tolerance to exercise and symptomatic with cognitive activity. And lastly is cervical, which we represent with decrease in range of motion. Definitions for the oculomotor movements. Saccades is rapid eye movements between two fixed objects or points. Smooth pursuits are eye movements that allow a person to track a moving object without moving their head. Tracking is the ability to keep an object in focus as it moves across your field of vision. VOR, the vestibulo-ocular reflex, is a reflex that allows for gaze stability when the head is moving. And convergency is the ability of the eyes to move inward to allow someone to maintain focus on a close object. You can click on the link to see the demonstration for testing of oculomotor functions.
The sideline concussion assessment. This is typically performed by an athletic trainer, medical doctor, or EMT on site during a sporting or traumatic event, but can be performed by anyone as a quick concussion screen and determine the need for medical emergency services. The SCAT-5 is an easy and quick assessment of concussions to determine the need for referral to a primary care physician, urgent care, or the emergency department. It consists of 5 steps including red flags, observable signs and symptoms, memory assessment, neurological assessment, and a cervical spine assessment. We will delve deeper into each of these categories in the upcoming slides. Step 1 of the SCAT-5 is red flags. This first step will determine the need for activation of EMS and transportation based on the following findings, deeming a medical emergency following a traumatic brain injury. If the patient presents with central neck pain and tenderness, diplopia, weakness or tingling in the extremities, severe or increasing headache, seizure, loss of consciousness, severe vomiting, increasing restlessness, agitation, or if the athlete becomes combative. Other signs to be aware of following any head trauma are fluid leaking from the ear, bruising at the base of the skull, and bilateral black eyes, indicating a skull fracture, which is a medical emergency. Step 2 of the SCAT-5 are the observable signs and symptoms. These are common signs and symptoms seen following a traumatic brain injury and will determine the need for further evaluation, including lying motionless, balance deficits, coordination changes, disorientation and confusion, a vacant or absent stare, as well as any visible facial injuries. Most of these signs and symptoms will be observed as you are approaching the patient and do not require another examination. Step 3 of the SCAT-5 is the memory assessment. This step consists of Maddox questions, which are as follows. Who are you? Where are you? Who scored last? What time did the game start? And what team did you play last week? These questions are scored out of 5 points and only validated for use during sideline examination and diagnosis of concussions. These questions can easily be altered to fit into the environment in which you're evaluating the patient. The importance of Maddox questions is to have a quick orientation to time, place, and person. Step 4 of the SCAT-5 and sideline assessment is the neurological examination. This is where athletes and patients will be given their GCS or Glasgow Coma scale. Each behavior has a scale for rating. An eye-opening response receives 1 point for no response, 2 points if they open to a pain stimulus, 3 points if they open to speech or sound stimulus, and 4 points for spontaneous opening. Next is the verbal response to a stimulus and is as follows. 1 point for no response, 2 points for incomprehensible sounds, 3 points for inappropriate words, 4 points for a confused response, and 5 points for orientation to time, person, and place. Finally, a motor response is provoked and scaled as follows. 1 point for no response, 2 points for abnormal extension, 3 points for abnormal flexion, 4 points for flex to withdraw from pain, 5 points for moving to localized pain, and 6 points when they follow the command. The GCS scale for severe brain injury is anything less than 8 points. A brain injury is considered moderate if they score anywhere from 9 to 12 points, and a mild brain injury is anything greater than 13 points. The final step for the SCAT-5 and on-field evaluation is the cervical spine assessment. This is used to determine if there's a cervical spine injury in conjunction with a concussion that requires stabilization and medical transportation. Signs and symptoms to be aware of are pain at rest and midline following impact. If there is no pain at rest, you can continue the cervical examination and determine if they have full range of motion, normal strength and sensation in the upper extremities, or where there may be deficits. Following the SCAT-5 and removal from the field, an off-field evaluation will be performed. This will include more details and is used for mild to moderate brain injuries. If a patient presents with a severe brain injury, they will have EMS activated and will not require further testing by the medical staff on site. The off-the-field evaluation will include the medical professional determining athlete background and demographics, such as previous concussions or any learning disabilities that may affect the remainder of the testing. This will be followed by a more detailed symptom evaluation, including the symptoms present and the intensity of those symptoms filled out on a PCSS, or a post-concussion symptom scale. Next is a cognitive screen, including orientation and immediate memory, using 5 words such as carpet, apple, bubble, saddle, and pencil. You will say the words to the athlete or patient and have them repeat them back to you, as many as they can and in any order. Have them remember those words for later on. Following the immediate memory, you will have the patient say the months in reverse order, followed by a series of digits starting with 3 numbers at a time. Have them repeat the numbers backwards to you and increase to a 5-number series, such as 15, 21, 11. They would respond with 11, 21, 15. Finally, a comprehensive neurological and cranial nerve exam will be performed with a final delayed recall of those first 5 words given to them: carpet, apple, bubble, saddle, and pencil. The post-game assessment is typically performed the following day. This will include a formal post-concussion symptom scale on immediate symptoms on the field, current symptoms, and then continue to use this sheet to record symptoms each day. A King-Devick test can be performed, which is to the right of this slide. The King-Devick consists of a demonstration card and 3 test cards, where they will be timed on how quickly they are able to read left to right through each test card. The time is paused between each card, and the cards will get progressively harder, with decreased lines and spacing between the numbers. You will also be watching for any errors and record the amount of errors along with their time. The normative values for the King-Devick testing is 54.3 seconds plus or minus 21.6 seconds, with an average being 42.2 seconds. Another test that should be performed following a concussion is the impact test. There should be an appropriate baseline prior to starting the season, and a retest should be performed following medical clearance. On this slide is an example of the scoring card following completion of the impact test. On this page, you're looking at the differences between baseline and each phase of injury to look for any abnormalities, decreases in reaction time, decreases in correct answer, and decreased impulse control. Athletes and patients should not return until all tests have returned to baseline and is cleared by the treating physician. As we can see on sample Sam here, he starts at his baseline with a memory composite score of 98, a visual motor speed composite score of 50.42, and a reaction time of 0.47. At his post-injury 1, he has about a 20 to 30 point decrease depending on the composite score, followed by post-injury 3, where he has increases in his score but is still about 10 to 15 points below his baseline. At post-injury 4, he is about normalized, with some decreases still in memory composite and visual motor speed, but an improvement in reaction time. This is when Sample Sam would be ready to begin his return to sport testing and have a safe return.
Outpatient evaluation. History taking. It's important to get the mechanism of injury, date of the injury, was there loss of consciousness, is there a history of previous concussions, and if so, what were the symptoms, what was the severity of the symptoms, and how long did the symptoms last? Is there a personal or family history of migraines or headaches, and did they use glasses or contacts prior to the injury, or are there any other visual conditions that we need to be aware of? Identification of signs and symptoms. What were their initial symptoms at the time of injury? How did the symptoms progress over the next few days? What are their current symptoms? Do they come and go? Do they change with activity? What is the severity of the symptoms? And what makes the symptoms worse? Range of motion and strength, assessing cervical range of motion, flexion, extension, side bending, rotations, see if there's any limitation and or pain compared to sides, doing a quick cervical strength assessment as well as upper extremity assessment, looking at shoulder flexion, abduction, and shrugs. Palpation, assessing for areas of tenderness, looking at the cervical spine, upper trap, see if there's any spasms, thoracic spine, facial structures, and TMJ, as well as the suboccipital region. Cervical spine assessment, just looking at general palpation, see if there's any tenderness, and the mobility to see if there's any restrictions. Posture, observing just general cervical and head position and sitting. Is your head forward? Is it tilted to one side or the other? Is there increased or decreased cervical lordosis? Looking at the thoracic spine, increased thoracic kyphosis, looking at the arm swing during gait. Is there a lateral trunk lean? And then overall, just observing when they come into the clinic, looking at their gait pattern, looking to see how well they are balanced when they first stand up, and just overall how they're moving within the environment. Balance testing. The best testing, test the balance with feet together, eyes open and eyes closed, tandem stance, eyes open, eyes closed, and then single leg, eyes open, eyes closed. The Romberg test, double limb stance, feet together, hands at hips with eyes closed. Also assessing head turns with walking, measuring the time between each movement to see if it's symmetrical. Visual testing, looking at Saccades, Soothmer-Spoots, VOR, convergence, and general visual acuity, specifically watching for equality, nystagmus, sluggish, response and tracking, and note their symptoms, eye pain, dizziness, nausea, that associate with eye movements. Functional tests that can be used on an evaluation. You can use the balance error scoring system, which is the best, the Tonetti, the Berg balance scale, the Buffalo concussion treadmill test, and the Fiduca step test. Education to patients. The most important thing we can do is validate their symptoms. Unfortunately, their symptoms are not always seen. Their impairments are felt, not been able to see. So it's important that we acknowledge and recognize that they are feeling symptoms. It does cause anxiety when patients, family members, and or athletes or friends can't see what's going on with them and they don't understand what's going on with them. So we just need to be very mindful that they are going through stuff and we have to validate that what they're feeling is normal. For patients that have light sensitivity, using blue light glasses and or filters on computer screens will help with their eye symptoms and fatigue. Limiting their screen time, giving themselves visual breaks so that they don't get to the point of having headaches, blurred vision, or other symptoms. Avoid alcohol and recreational drug consumptions. Avoid flying. Areas to be aware of, getting patients to be on board with treatment, and being symptomatic with progression is completely normal, and getting them to understand that they are going to feel worse before they start to feel better at times.
So, now that we have fully evaluated our patient, it's important that we appropriately document our findings to guide future treatments as well as to justify the need for insurance authorization. Frequently utilized outcome measures and functional tests are listed here. Due to the fact that concussion patients have a diverse symptom presentation and possibly other orthopedic complaints accompanying their concussion, it is at the therapist's discretion to choose which tests and measures will be the most appropriate for the patient. Goal writing. As with any patient we treat in our clinics, we strive to make our goals specific, measurable, attainable, and relevant. You will see here some examples of goals and goal topics. When writing a daily treatment note for a concussion patient, it is important to note baseline symptoms upon entering so that you can monitor change throughout the session as well as over time with skilled intervention. Any pertinent changes throughout the session should be documented. It can also be helpful to note the environment and whether it be in a darkened treatment room, in the busy clinic, or something in between. I also like to document how long it takes for symptoms to resolve when you provide patient with a rest break. I also will note at times my strategies, such as if we are working on ocular motor and then we switch gears to more traditional strengthening exercises to give the eyes a break and then return to ocular motor once their concussion symptoms have calmed down. With our recent transition to EPIC here at Connecticut Orthopedics, we now have smart phrases that we can utilize to help make documentation time more efficient. Our group has created some smart phrases to share with you all, and we also encourage you to build upon these as you see fit. This will make your life easier when it comes to doing the evaluation as well as treatment sessions, reevals, and discharges.
The next section is going to touch on treatments. It is important to remember treatment is based on the patient in front of you and how they respond in real time to each stimulus and exercise. In this section, we will discuss some basic concepts and talk more in depth during the live portion of this course. Before starting treatment with a patient with a concussion, it is important to understand their timeline. There is quite a bit of variability to recovery following concussion and return to baseline, as well as return to sport and higher level activity. The timeline is vaguely based on how long it takes for the symptoms to resolve, being anywhere from days to weeks to months. The tolerance to activity as it is introduced and changed, and whether or not there was a loss of consciousness at the time of the traumatic event. A loss of consciousness will increase healing times and prolong return to activity. When treating concussions, it is important to assess provocative activities involving neurocognitive function, exercise tolerance, and their vestibular ocular function. The patient will be fluid within their timeline, having good days and bad days, but is based on their symptoms and should be treated by their symptoms and how they present each day, not how they presented the day before. There are some general guidelines to treating concussion. The general guidelines to treatment include treat the headache first. To treat the headache, you can utilize various manual techniques such as trigger point release and dry needling, as well as cervical and thoracic mobilization. There has been research that shows that suboccipital injections help relieve headache and muscle tension to improve concussion-type symptoms. It is best to start the patient in the safest position, starting with seated exercises and progressing to standing, then dynamic. This will allow the most appropriate progression of symptoms as well as the safest option, especially as you begin balance activity. Determining when you're ready to move to the next step will be based on patient presentation, recovery time with exercise, and increases in symptoms outside of the clinic. If patients have different activities that they have to be involved in, work, school, extracurriculars that are required, this may increase their symptoms for each time you see them. The symptoms should be treated for the day and how they present in that exact moment. It is fluid and it will change throughout the session. Strength training should be included when treating concussions. This should include strengthening of the deep neck flexors to potentially help prevention of a concussion in the future, as well as postural strengthening and impact-based activities. The impact-based activities are important for sport-specific training. This allows the athlete to practice potential conditions, drills, or contact that they may face upon return to their sport, such as a gymnast landing from a flip or a football player being hit on the field. Next up is ocular motor training. Ocular motor training can consist of any activity involving vision training with static or dynamic body movements. Some examples include training saccades by using a word search or looking between two stationary objects. Smooth pursuits can be treated by passing a ball or tracking an object. The use of a straw and a golf tee can help train convergency by having the golf tee in one hand and the straw in the other, while in front of you you're trying to place the golf tee into the straw. Incorporating head movements with focus on an object can help to train the vestibular ocular reflex. It is important to be creative in this area and use various methods to train all ocular motor deficits. This will change day to day and can be used in conjunction with strength training as well as balance. Balance is typically another area following concussion that requires treatment and has multiple deficits. The use of a laser and tracking can incorporate ocular motor training with balance and challenge the patient to a more real-life scenarios. They can follow through a clock pattern as well as through mazes, or have them follow around the clinic to different objects using their laser and keeping their head focused in midline. As with other treatments, balance should be started in the seated position. Once they are comfortable in this seated position, you will progress them to standing with static movements. When they are good with static movements without any significant deficits or challenges, then dynamic movements should be increased. As the symptoms improve, their reaction time improves and recovery time decreases. The patient can progress to balance based on sport-specific activity, work-specific activity, or daily activities that this person wishes to return to. Cognitive thinking is an area that can be addressed during physical therapy. During these sessions, it's typically incorporated with strength training or balance, as well as ocular motor training. Patients can be asked to match colors while balancing on one leg, recite national parks while performing ocular motor training, perform word searches, or do puzzles while completing any other task. The importance with cognitive thinking is to also incorporate intended distractions. We don't live in a world where everything is straightforward without changes of light, distractions, people, cars, other areas of work. Being able to train cognitive thinking is important for return to work, return to school, and return to daily activities. While we are incorporating cognitive thinking, it is important to remain goal-oriented. While a word search may be fun, it should be related back to what the patient needs to return to do. The needs of the patient should come first. If they have to bounce between multiple monitors as well while talking on the phone or typing, that is something that should be practiced with cognitive thinking, ocular motor training, as well as seated balance and strength training. Management of the lingering symptoms is often the most difficult part of concussion rehabilitation. Managing the lingering symptoms is going to be normal. This will change day to day and will be based on the severity of concussion, as well as if they had any recent prior concussions, the age of the patient, and specific needs that they need for return to activity, work, or school. The important part of managing the lingering symptoms is to return to manage the headache first. Go back to the basics, use your manual skills, followed by what are their ocular motor deficits, what are their balance deficits, what areas in their day-to-day activity are they having difficulties with? How can we recreate those in a clinic situation? For example, a patient is having difficulty getting off an escalator, but they need to for work. You can set up a treadmill on a very slow speed, have the patient walking backwards, and then follow the edge of the treadmill as if they're walking off that escalator. Can you add in distractions such as people talking around, as well as things like asking them questions, changes in light, as well as balance training. The final step of concussion treatment is the return to activity and sport. To determine if someone is ready to move to this final step, all previously discussed topics must be combined in a series of activities. A patient should be able to perform cognitive thinking with dynamic balance and ocular motor training all at the same time, such as standing on one leg on a foam surface while balancing through different objects and focusing on different objects while being asked questions or distracted. Strength should have improved, along with posture and decreased rest breaks. Rest breaks are important during rehabilitation, but a decrease in the need for rest breaks and time between ocular motor training, as well as strength training and balance training, is important for improvement of symptoms. There is a 6-step process for returning to sport and is as follows. First step is rest. Second step is light aerobic activity. These first 2 steps are typically started immediately following the concussion protocol. Patients will start with a period of rest. When symptoms begin to resolve, they can begin light aerobic activity such as biking and walking. Step 3 is more sport-specific exercise and training. This is typically when they are cleared by the treating physician to begin higher level activities. This will include strength training, agility, and that impact-based activity. Non-contact training is step 4. This will include stick and ball drills, passing, shooting, learning and performing plays as able but not allowing for any contact from another member of the team or coaching staff. Step 5 is a full contact practice. A full contact practice must be completed while remaining asymptomatic before they can return to full game conditions that are explained in Step 6. Step 6 is that return to normal sport activity. This 6-step process can occur over weeks or months based on the severity of symptoms and sport demands, but they must complete each section without symptoms before moving on to the next. If symptoms do arise during any of the sections and steps, then they are required to return to the previous step where they did not have any symptoms and cannot move forward until they remain asymptomatic. Students must also be off all academic accommodations before being allowed to return to full activity. This can be used for not just high school and college athletes as well as professional athletes, but can be used for any patient who needs to return to work, as well as just general activities such as pickleball, tennis, running, or any other recreational activities that someone wishes to participate in. This 6-step process can be draining and demanding on patients as well as frustrating, but is important to follow each step to ensure safe return to play and decrease the risk of continued concussions. The next few slides here are the case studies that will be discussed during the live portion of the course. Take the time now to review these slides and prepare any questions or discussion topics in advance. Case study number 1 will involve John, a 32-year-old male involved in a car accident. Case study number 2 will be based on Olivia, a 19-year-old collegiate gymnast. And finally, case study number 3 will be based on Mike, a 23-year-old baseball player.